Yeah.
So the next question is probably for myself and potentially Dr. Kalkar as well too. How do you know what subtype of acute myeloid leukemia you have? This is a great question and honestly extremely challenging to answer. And the reason why I say that is because I think we do a disservice to our patients right now because there are two competing diagnostic criteria for acute myeloid leukemia and myelodysplastic syndrome that do not align. And this is a big problem because there are some criteria that would say a patient has MDS and some that says patient has AML. And we tell patients, you could have either depending on which criteria we are looking at. We're this problem will be solved next year when there's going to be a unifying consensus. So that's number one, is that it's currently very confusing. Number two is that there are many different ways that you can call a subtype. You can call a subtype based off how it looks under a microscope. You can call a subtype based off of a risk for progression of disease or overall survival or chance of relapse to transplant. That's a very useful risk stratification system way to think about subtyping. But I think a more pragmatic way to think about subtyping is how does it affect my treatments? So, in my opinion, the most effective way to think about this is do I have a targetable mutation? So, what I mean by that is that in acute myeloid leukemia, there have been a number of genetic mutations that we've identified that quote unquote drive this leukemia to exist. And we can similarly turn off that driver leukemia gene with therapies. So you may have heard of NPM1 or FLT3 or IDH1 or IDH2. These are very important, or KMT2A rearranged. These are very important molecular targeted genetic abnormalities that a patient may have in acute myeloid leukemia that have therapy decisions associated with each one of those. Or you may not have any, and therefore you are kind of the de novo agnostic leukemia and therefore get kind of the traditional chemotherapies. In my opinion, that's the most useful way to think about it. All the other systems are very complicated and probably are better reserved for physicians to kind of interpret. Dr. Kelkar, do you agree with that? Maybe
Yeah.
a better
Very.
way to think about it?
No, I similarly use a similar system, and obviously being a transplanter, I think for us it very much is this disease subtype that's going to benefit from more frontline treatments and kind of delaying transplant, like say a lower risk NPM1 leukemia that doesn't have secondary mutations and might and is MRD negative and might benefit from being monitored and not getting a transplant versus some higher risk types. So again, I guess the molecular ontogeny I think has well, for better lack of a better term, the types of mutations that your leukemia has are I think right now the most useful things as a patient to help determine what treatments you're getting. So I very much agree with the way you're thinking about it in terms of how patients should look at it.